Okay, beautiful. So yeah, we're going to talk about the art and science of neuroplastic surgery, what it is, why is it important, um, and um, and actually what is what needs to be done based on the future of this, where we're going with this, why is it important, and hopefully inspire some of you guys to pursue such an interesting career, or at least get interested. Neuroplastic surgery is basically a hybrid between neurosurgery and plastic surgery to bridge the gap in between those two intersecting disciplines. And we are dealing with complex cranial reconstructions, and we essentially want to ensure that patients have complete preservation of their preoperative appearance. Now, why is this important? This is a patient that, let's say, underwent hemicraniectomy. I'm sure you hear about trauma and stroke. Um, and he needed a basically hemicraniectomy to remove half of his skull. Now he have a sunken flap, and he is a young guy. He wants to go back to looking like himself again, but the literature shows that the complication rates for such a procedure are pretty high. And basically what happens is that he wants to go back to his normal life. He wants to be reconstructed. He wants to go back to work, get married, have a job, hang out with his friends. But when he look at the literature, um, well, you'll see there is a large, risk for complication. And those can reach up to 40%. So with neuroplastic surgery, that was founded back in 2016, we tried to understand why this is such a high risk procedure and to change whatever we can control, like the technique and the timing and the biomaterials to really go, dive deep into this type of surgery. And we look at the data, and there is a lot of data out there. You know, 1 out of every 3 patients has a high risk to fail reconstruction, right? So if you think about it, any patient go to reconstruction, there is 35% risk for failure, either because of infection, because of feet, because of the material, because of seizures, because of wound problems, and that's where we're landing. So this is why we need a new subspecialty, and this new subspecialty is dedicated to the adult part of the craniofacial and neuroplastic reconstruction. Why is it so unusual? Because if you think about it, the brain surgeons are really at the forefront in the last 100 years, rightfully, to learn about the brain, about the vessels, about the biology of tumor, about the architecture of the vasculature, and plastic surgeons sort of in the background, really talking about everything. There was no subspecialty to really focus on those adults, neurosurgical patients, and this is what we call the blind spot, basically the no man's land, which is undefined and an area that is not owned by anybody. If you look at this diagram on the left side, it's very well established. The A woman get diagnosed with a breast cancer, she sees the plastic surgeon and the brain and the oncologist at the same time, and they go for surgery called oncoplastic reconstruction. When a brain tumor patients, for example, get diagnosed, you see us the neurosurgeons, but then if you have problem with the shunts, with leaks, with defects, with deformities, still the face, then there is no one entity that sees those patients and basically taking over. And this is the question mark that we try to answer. Neuroplastic surgery is a lot. You can be dealing with tumor, with strokes, with vasculars, with spine, with trauma, and this is a wide variety of type of cases that we actually are dealing with on a daily basis. And this is, for example, a paper that I had to review not too long ago. Was done somewhere else. This patient had a bleed, as you see in A, hemicraniectomy, as you see in B. They removed the half of the skull to let the brain swell. And then they came back for reconstruction with a mesh. And then after the reconstruction with the mesh, he had exposed hardware and exposed mesh here. And then they did 16 or 17 surgeries, I can't remember, and this is the final outcomes. And basically what you see here is a very unacceptable outcome on a patient after multiple failed reconstructions. This is what we want to avoid. This is basically what we do, and we're here to change. Some other cases that are challenging, those large, skull-based tumor that are basically spanning over a couple territories, nose, orbits, brain, skull base. Those are challenging cases, not necessarily because of the resection, but more because of the reconstruction, because then there's going to be a big hole. And then how do you reconstruct that hole? Same for this patient. She had a skin cancer that went all the way down to the bone and to the dura and to the basically and to the sinuses. And what you can see is happening is this patient is going to the plastic surgeon, which tells her, well, I see their CSF, I see brain, I don't touch this. She goes to the brain surgeon. The patient says, well, how do I get close this open scalp wound? And this is what we're here to basically change. What about this patient? Was walking around with basically exposed plate for multiple months. Nobody wants to treat it. Those are, very challenging operations that very few offer a substantial, answer. So what we did is we started to do some training and education, right? We went to the main textbook of, neurosurgery, and we wrote the book chapter to basically teach the principle of neuroplastic surgery and to elevate the awareness of such a thing. And we essentially wrote a very elaborated protocol how to fix scalp and skull defects. And what we showed in those large studies is that if you want to compare the risk for complications, if you go to a dedicated place or not a dedicated place, the outcomes are completely different. When you go to a dedicated place, you have much better rates of successful operation. Basically, if you go to somewhere that is not dedicated to this, every time you do an operation, it's a cumulative risk to have a worse and worse outcomes. And this is just for example, this patient he had a trauma many, many years ago with a large plate, and he went to the doctor with this chronic wound here. And he went to another center that tried to help him. After 7 operations, he now looks like this. So now fixing it is a much bigger problem. And it's not because, he had a bigger problem to begin with, but because the more tries you have to fix it, the harder it is. So neuroplastic surgery is this sort of hybrid between plastic surgery and neurosurgery, and we're really overlapping multiple different subspecialty, and I'll share a few of those. When we look at the outcomes, we checked basically our outcomes over 500 patients where I was trained back at Hopkins by the single center that started this. Dr. Chet Gordon is the founding father. The complication rates went all the way down to 15%. So this is Tucker again. He had a severe trauma, and he comes in with this defect, and we work with the engineers to basically design very sophisticated implants. And we take the patient to the surgery. We open the same incision. We put this implant. It looks like basically acrylic and clear. And these are the outcomes.
Well, a patient who was left with a deformed skull after a life-saving procedure is back to living a normal life thanks to a medical team at Lenox Hospital. Leading the team, the world's first neuroplastic surgeon. Eyewitness News reporter Sonia Rincon with more from the Upper East Side.
This is what Tucker Marr of Manhattan looked like only a few months ago. He loves playing hockey, but it was a tumble down a flight of stairs that landed him in emergency brain surgery.
I had a fractured right skull and a left-sided subdural hematoma, so brain bleed.
The surgery saved his life by removing part of his skull, since pressure on brain swelling can be fatal.
So for a while, that looked very normal, right? My brain was swelling, so it replaced that area.
Then the swelling came down. He wore a helmet to both protect and conceal.
It taught me a lot about how we as society and humans deal with deficiencies in other people.
When he came to us, he had a severe deformity and a dent in the side of his head.
But putting back the old piece of skull bone carries a risk of infection. Dr. Ben-Shalom at Lenox Hill Hospital is the first neurosurgeon to develop a specialty in neuroplastics, minimizing risk by 3D printing implants made of acrylics and performing a second surgery.
A lot of patients survived brain surgery, but they don't look like themselves again. They don't feel like themselves again.
This is what Tucker's implant looks like. It's reinforced with plates and screws. Dr. Ben-Shalom added extra ones, he says, because he wants Tucker to play hockey again.
The brain functions better when it's protected.
It may seem like a no-brainer, but Dr. Ben-Shalom's work, marrying neuro and plastic surgery, is catching on.
Everybody can do everything else the old-fashioned way, but I think, and I really believe this is a very novel subspecialty that's going to take off, and we'd like him to lead it.
Tucker Marr's scars are healing, and he's training to run the New York City Marathon, just as he was before he fell. With a reinforced skull and sense of optimism, he says he hopes to motivate others who may find themselves with challenging recoveries.
It does come. It doesn't matter how long it takes. It does take that mindset, and you have to keep moving.
Well, a patient.
So this is just, for example, how patient perseverance, works out. And obviously, Tucker made amazing recovery. His case was covered in the New York Times, and he was then running the New York Marathon. So what we try to do in neuroplastic surgery, if you think about it, it's not only dealing with a physical deformity and the physical defect. We really want to thriving to help patients feel complete and whole again, and let them go back to their normal life. The uniqueness about this acrylic ultrasound is the fact that we can do the ultrasound to the brain and look at the brain. So it's very reassuring. He comes to the office, we put a probe, and then we can look at the brain. Everybody's very happy to see that things looks great. And more and more research is coming out of this technology. If you think about it, CTs are radiation and takes time to coordinate, and patients need to go to either to their emergency room and whatnot. Here they come to the office, we put a little ultrasound, and for example, here we can see the size of the ventricles. And we wrote multiple papers about it, basically advancing this technology, which is adjunct to MRI and CT, to look at the brain pathology and whatnot through the ultrasound. Another case that I think is important to show, this patient already had a cranioplasty, and he already reconstructed after severe sort of trauma, but then he comes in with those double deformities you see on the left side. The reason is that because the implant was not designed right. The implants change and evolve over time. It's like iPhone, if you want to think about it. iPhone get updates every couple of months. This implant was very outdated, and he came to me saying, listen, I don't want to leave the house. I survived the trauma and I feel good, but I don't want to leave the house. And we had to think outside the box. And we took the techniques that we take from brain tumor surgery with the engineers, with our neurophysiology, to preserve all the important nerves that innervates the facial the muscle of facial expression. And then after really combining technology and the implementation of the surgery from brain tumor, this patient now looks like this. Could not be happier that he's basically can go back to his normal life. I'm going to skip some slides here again. One of the other things that we're doing is we're dealing with implantable neurotechnology, a brain-computer interface. This is essentially a very promising and kind of, I would say, novel and promising subspecialty, which you basically can enhance function. And this is one of the surgery that I did back in 2023, where we implanted 6 brain chips. And this patient basically restored a movement. He was C4 quad, meaning he had barely movement of his upper arms and shoulders, and now he's moving. Then we wrote the second book chapter in the main neurosurgery textbook, which is brain-computer interface, how to integrate all those devices into the brain. If you think about it, working around the brain and the dura and the covering is as important to recovery. So if you focus on the chips only, but you don't focus on the brain and the dura and the covering and this, let's say, scalp, breaks, then it's a problem. So we want to make sure it's not happening. Then I want to show you this case, and I'll leave some questions. This is basically, a patient with a large tumor, as you see on the MRI, invading the bone and the brain and the dura and the skin. As you can see, this patient is very much deformed because of this tumor. So surgery is basically to remove and to resect. That's one portion of the operation, but then to put everything back together, which is as challenging. So we basically, what we do, we take these patients to preoperative embolization to reduce the risk for bleeding in the surgery. And then we use all the augmented reality software to put everything into one goggles. We do the 3D printing to basically have a one-to-one model in the patient's face, and so we can learn and augment all our different technique, both surgery for resection and reconstruction. And then we take into surgery. We create this large, incision to basically expose everything. We remove the tumor, and then we reconstruct everything with an implant. It fits like a puzzle piece. So when he's done, he looks like this. Okay, and I would like to show you a video.
My name is Hiju Yi.
Do you see the video, by the way, Christy?
I don't see the video. I hear it
Okay.
though.
Let me try to do it again.
Live in Brooklyn,
It
Williams.
works.
Do you see the video now on full screen?
Yes.
Okay, great. Let's start it over.
My name is Hiju Yi. I live in Brooklyn, Williamsburg. I grew up here since 1978. I love New York City.
So I met Hiju because he had noticed that on his forehead, this mass got progressively larger. He came with a history of having cancer of the liver. And so we were concerned that this may represent a mass that had metastasized from his cancer and gone to the scalp. And importantly, it was pushing on his brain.
So Hijo came to our brain tumor center to meet with our experts. The minute we saw him together, we realized that Hijo needs essentially two different procedures. We combine those two procedures in one operation, and we are giving the patients a very personalized treatment.
So taking the tumor off of his brain is essentially my role. And what Dr. Ben-Shalom is an expert at doing then is putting the frame back together of the skull. The whole reconstruction of the exterior of the skull is what neuroplastic surgery focuses on.
Today, we really want to replace patients' own skull with implants man-made with computer design to create a custom implant that will cover the expected defect. Meanwhile, we print the patient's skull model, and using augmented reality, we can actually operate on Hiju and practice and learn his specific anatomy before we go into his procedure.
What I think is really unique about this neuroplastics program at Lenox Hill Hospital is you're getting the cosmetic and reconstructive component of these operations, and that improves our patients' outcomes.
Our goal is to make sure that the patients do not appear as if they had brain surgery.
It's a wonderful now. I'm really happy about the surgery and my face and my head. It's a wonderful job. Yeah, that's it. Yeah, beautiful job.
He Choose Care is really just an outstanding example of true excellence in surgery. This multidisciplinary approach is just quintessential to a successful outcome for our patient.
At Lenox Hill, we really give the most sophisticated level of care and really give patients everything that medicine has to offer. All right, I'll stop here and take any questions.
All right, perfect. We have one question that says, as implantable brain-computer interfaces continue to advance, what new surgical or reconstructive challenges do you anticipate for neurosurgeons, particularly regarding implantation, long-term biocompatibility, and revision procedures?
Yeah, so that's a good question. The more we expand, the more we'll have to make sure that those implants are long lasting and scalp is not breaking. If you think about the complication rates of cranioplasty, which are essentially foreign bodies are being put into the skull, we have to make sure that specifically when those expensive, and very important technology goes in, they're durable, they are long term, and there are ways to hide it in a way that patients don't have big bumps on their head and also do not need repeated surgeries to deal with complications. So the design needs to be accommodating for the scalp.
Another question asked, you discussed the ability for the implant to restore head movement and control. Do you believe that an implant to restore full body function is possible?
There is no relationship between implant and full body, but there is a relationship between restoring the skull and also the brain environment. So we know that the brain function in a closed space environment. So the restoration is definitely to enhance the brain capacity for rehabilitation.
Another one is asking if you've seen a difference in success rate using a 3D printed clear skull implant versus when using patient's natural preserved skull versus another material you may use.
Yeah, so what I can say is we know to say that patients' own bones are outdated and are inferior to 3D printed models. After 20 or 30 years of research looking at the differences and comparing between native bone or autologous bone to alloplastic material, we found out that alloplasts do better than bone, bottom line. So we at least in our practice, we don't use bone anymore.
Another person asked, how often does a patient have to come back to have their refixed brain shaped due to the material?
Never. It's for life.
It. If you could talk a little bit more about how you got into the specialty.
Yeah, the short version is that as a resident, I saw a problem. I saw that there is a need. I saw there is a big problem that have not been met or addressed. And there were no good answers. And I started to explore and I started to dive deep into finding the solution myself. And this is where I found the group at Hopkins that are focusing on that specific, patient population, which encouraged me to go there and do research. And during that research, I basically learned and realized there is another world that we're not being told about or taught about in residency. And this is where I really decided to dedicate my career into exploring, expanding, and pushing the boundaries with that specific subspecialty.
Right. And just to clarify for the BRAINterns, it is a fellowship after your residency.
Correct.
Perfect. Another question asks if there's been any long-term complications or limitations you've encountered with the 3D printed cranial implants.
Like any hardware, any foreign bodies, patients when they age, they lose the thickness of the scalp, the implants can get let's say there is the risk for problems. If you think about a patient that had an implant or a hardware, like the patient that you saw in the first images for years and years and years, when patients age, scalp getting thin, patients fall, they can have issues, and those issues usually are related to thin scalp and broken scalp.
Going back to kind of about the implants, somebody had asked why is that the alloplastic does better than bone?
Basically, the study shows that it's better for infection rates are lower. Cosmetic definition is better, and there is no bone resorption. One of the problems with bone is that because it's avascular, it's getting resorbed by the body, something that cannot happen with alloplasts.
What are some factors that you determine for whether a patient is suitable candidate for surgery?
Every patient is candidate for surgery.
Let's see. What advice would you have for international students who may be interested in doing this fellowship?
Apply. There are no tricks here. Just get through residency, get to fellowship, and apply. No tricks.
Someone asked if neuroplastic surgery includes both adult and pediatric care.
So that's a good question. We deal with adults only, right? Because the craniofacial surgery, it's a field that was established back in the 70s to treat the holistic, multidisciplinary care for pediatric population. We deal with adults only.
Another question was kind of talking about whether you practice general neurosurgery as well or just focus on the reconstruction. So maybe you can talk about kind of how your schedule of the balance between the two.
Yeah, no, my practice is everything, right? I do general surgery, I do oncology, I do everything that comes in the door. And I try to build a niche for those specific tumor reconstruction. If you think about brain tumors involve the scalp or the skull, or tumors that involving, other tissues after multiple operations, they're more complex to operate because of the change for the scalp. So the niche is, fixing those skull tumors to both resect them and reconstruct them.
Someone had asked if, so obviously you've had some patients who may have gone to other surgeons or been told no, with surgery. So they're asking if you've ever had patients who are skeptical about entrusting you and your team due to repeatedly unsuccessful attempts before that, and how do you go about that interaction?
So redefine the question. I'm not sure I understand it.
I guess the question is how you go about if a patient comes to you and they are, let's say they've gone to a different surgeon who may have attempted and maybe it wasn't as successful. I guess the question is how do you go about, I guess, the bedside manner in trying to, I guess, help give them some confidence in the surgeries.
Listen, we don't sell anything here, right? We're not salesmen. Patients come to us after they did the due diligence. If they come into second opinion, we don't need to sell ourselves. They can look up, talk to other patients, look at the website, and get confidence. I feel like most patients, when they come here, they get a sense of confidence because they already did the homework. If they come here, they already, did the right due diligence to say, well, those guys know what they're doing. We don't sell, we don't convince anybody.
Someone asked, what are the limitations for a neurosurgeon, especially in brain tumors? Like which areas of brain involved become untreatable?
There is no straightforward answer here. It very much depends, right? Every case by case, it's a different story.
What are some of the biggest unanswered questions in reconstructive neurosurgery that you feel the field should prioritize over the next decade?
It's a good question. That's something we think about all the time. What else we need to do? What else we need to address? How do we change the current treatment paradigms? And I think that recovery is going to play a central role in surgery, right? Basically, the recovery is what's going to define the good outcomes, and we are focusing to understand what can we do better once we did a fancy operation and we have the technology for the operation. What else can we do with recovery? And there is a big team of people that helps to get the entire patient as a system and not only as a problem, to look at the nutrition and sleep and mental and emotional and physical, to really help the body to heal more in a holistic way. This is what we try to encourage our providers here with the neuroplastic surgery, to look at the patient as a whole, not only as a problem. And I think that what we need to what we're doing to get better is to really focus on their recovery, right? How do they sleep? How do they eat? How do they exercise? What other modalities they do to reduce inflammation? What other sources of vitamins we can give them? What other disciplines need to be involved, emotional, physical, infectious disease, to treat those patients basically as a system and not only as a problem. I would say this is the main thing that we're going to see in the next decade.
Going back to a little bit about the possibility of pediatric neuroplastic surgery, they're kind of asking if you think that will be possible and emerge since brains in schools are still developing when you're
Yeah,
young.
it's already an established field. So this is already an established field called cranioplastic surgery, as I said, was started in the 70s. And this field is very well established in the pediatric population. They did amazing. They built amazing reputation, but it was still lacking. It is still lacking for adults. I'll take one more questions, and I
Sounds
got.
good. Last question. How do you address if the body doesn't want to accept an implant? Do you end up trying different materials, or different
Yeah,
technologies?
if I see patient that failed, let's say a certain biomaterial, and they come to me, or she comes to me, or the patient comes to me after they failed and it didn't work, I never use the same material again. I change materials.